welcome to the deep dive. Today we're focusing on a really specific skin condition. Discoid Lupus Erythematosus, DLE.
That's right.
We're working from some revision notes, and basically the goal here is to pull out all the crucial bits so you get a really solid handle on DLE.
Sounds good.
So let's just start at the beginning. What exactly is Discoid Lupus Erythematosus?
Okay, yeah. So Discoid Lupus Erythematosus, or DLE, it's a chronic autoimmune thing, but it specifically targets the skin.
Autoimmune, okay.
Yeah, and the key things you see are these inflamed sort of scaly skin lesions. They can be quite disfiguring sometimes, and they usually pop up on areas that get a lot of sun.
Sun exposure, makes sense.
Exactly, and importantly, it tends to just stay in the skin. You don't usually get the systemic symptoms affecting internal organs like you might with other types of lupus.
All right, so it's more localized.
Generally, yes, but and this is crucial, if you don't treat it, DLE can definitely lead to permanent scarring.
Okay, permanent scarring, noted. So you said autoimmune, the body's attacking its own skin. What actually kicks this off? What's the cause, the etiology?
Well, it's thought to be a combination, really. There's a genetic side to it. Some people are just more genetically predisposed.
Right.
And then there are environmental triggers, things that can sort of start it or make it worse. It's essentially an autoimmune response where the body mistakenly flags its own skin antigens as, foreign and attacks them.
So nature and nurture, in a way.
Yeah.
Genes and environment. Are there specific things that make someone more likely to get it, the risk factors?
Yeah, definitely. We know a few key risk factors. That genetic predisposition we mentioned is one.
Okay.
It's also more common in women.
Interesting.
Exposure to UV light, ultraviolet light is a big trigger, big risk factor. And smoking. Smoking is also linked to a higher risk.
Right. Smoking seems to pop up everywhere.
It really does. Actually, there's a mnemonic that might help remember this.
Oh.
For us guys, smoke.
Oh, nice. Say that again.
For us guys, smoke. Female, UV light, genetic predisposition, and smoking.
FUGS. Got it. That's useful. Okay, so the immune system attacks the skin. Can we go a bit deeper into how that actually works? The pathophysiology.
Sure. So basically, the immune system gets confused and targets healthy skin cells. This attack causes inflammation, which then leads to damage in the skin tissue.
Right.
You also get these things called autoantibodies, involved antibodies attacking the self, and immune complexes, which are clumps of antibodies and antigens. These basically add fuel to the fire, contributing to the inflammation and the tissue injury you see in the DLE lesions.
So it's like a whole cascade of immune responses gone wrong in the skin.
Exactly. You've got immune cells, like T cells, getting activated when they shouldn't be, right there in the skin layers.
Okay, so if someone comes in with skin issues that look like this,
Yeah.
how do you know for sure it's DLE and not something else? There must be lookalikes, right? The differential diagnosis.
Oh, absolutely. That's a really important point. Quite a few conditions can mimic DLE, so getting the diagnosis right is key for the right treatment.
Makes sense.
You definitely consider systemic lupus erythematosus, SLE, because as we said, there can be overlap, or DLE can be a feature of SLE.
Right.
Then there's dermatomyositis that affects skin and muscles, plaque psoriasis, which is pretty common, actinic keratosis, those precancerous spots, lichen planus.
Wow, okay.
Yeah, warts, sarcoidosis, even skin cancers like squamous cell carcinoma, or rarer things like cutaneous T-cell lymphoma, and sometimes even syphilis can present with skin signs you need to consider.
That is a long list.
It is. It highlights why a proper workup is needed. There's another mnemonic, actually, for some of the main ones, though it's a bit of a mouthful. Some do prefer a large wart sitting squarely cutaneously.
Okay, let's try that. SLE, dermatomyositis, plaque psoriasis, actinic keratosis, lichen planus.
Warts, sarcoidosis, squamous cell carcinoma, and cutaneous T-cell lymphoma.
Got it. Helps break it down. So, okay, putting DLE in context, how common is it, say, here in the UK? What's the epidemiology look like?
Right. So in the UK, DLE is actually less common than SLE, the systemic form.
Okay.
It mostly affects adults and, like we said, more common in females. The numbers vary a bit, but the estimated prevalence is somewhere around 17 to maybe 48 cases per 100,000 people.
So not super common, but not incredibly rare either.
Exactly. And the typical age it shows up is usually between 20 and 40.
Prime of life, really.
Yeah. And worth saying, again, smokers have a higher risk. And you can see DLE alongside SLE sometimes.
Right, that overlap again. Okay, so we know who tends to get it.
Yeah.
What would someone actually see or feel? What are the clinical features?
Okay, so how it presents, it can vary, but there are patterns. You get localized DLE, often on the head and neck. Scalp and ears are really common spots.
Scalp and ears, right.
Then there's generalized DLE, which can be above and below the neck, often on the outside of the forearms, the back of the hands.
Extensor surfaces.
Yep. And it can hit mucosal surfaces too. Lips, inside the mouth, nose, even genital areas.
Okay. And the lesions themselves.
They usually start as these red, scaly, flat spots macules or little raised bumps, papules.
Uh-huh.
Then they tend to develop into these quite characteristic coin-shaped plaques. That's where the name discoid comes from, like a disc or coin.
Ah, okay. That helps remember it.
Yeah. And these plaques have scales that are really stuck on tight, apparently. It can be quite painful if you try to pull them off.
Oh,
And if they're on the scalp and go deep into the hair follicles, they can cause scarring hair loss alopecia. That's often permanent.
oh, right. That's significant.
Definitely. And then older lesions, ones that have been around a while, they tend to become atrophic. The skin gets thin there. And you often see this pattern of a dark ring around the edge, that's peripheral hyperpigmentation, and a lighter area in the middle, central depigmentation.
So they change appearance over time.
They do. And another key thing, sun exposure or any kind of skin injury or trauma can make existing lesions worse or trigger new ones.
Okay, so sun protection is going to be huge.
Absolutely critical.
Yeah. So with those features, how do doctors lock down the diagnosis? What investigations are usually done?
Well, a lot of it is based on spotting those clinical features we just talked about. The look of the lesions, where they are, that gives a strong clue.
Right, the clinical picture.
Exactly. But often, to be really sure, you'll need a skin biopsy.
Take a small sample.
Yep. Send it off for histological examination, look at it under the microscope. And for most people with DLE, if you do a special test on that biopsy called immunofluorescence, it'll be positive. It detects immune proteins in the skin.
Okay, so biopsy is key for confirmation.
Often, yes. Interestingly, the standard blood test for lupus, the ANA or anti-nuclear antibody test, it's only positive in about 20% of people with just DLE. It's much more common in SLE.
Ah, okay. So a negative ANA doesn't rule out DLE.
Not at all. Other blood tests might show some non-specific things, maybe a low white cell count or a raised ESR that's an inflammation marker or low complement levels, sometimes.
And urine tests.
Yeah, a urinalysis might be done mainly to check for kidney involvement, looking for protein, albuminuria. That would be more suggestive if it's perhaps evolving towards SLE.
I see.
But even if it seems purely skin-based at first, doing periodic blood tests is important just to monitor and make sure it's not developing into systemic disease over time.
Okay, so clinical exam, biopsy, maybe some bloods for confirmation and monitoring. Makes sense. So once it is diagnosed, how is DLE managed typically here in the UK?
Right, management. The absolute cornerstone, number one thing, is minimizing UV exposure. Sunscreen, hats, protective clothing are really vital.
That ultraviolet terra mnemonic comes in handy here. Minimize UV.
Exactly, perfect link. Then, for the lesions themselves, topical treatments are usually the first step. That means creams or ointments.
Like steroid creams.
Yeah, topical corticosteroids are common, or sometimes calcineurin inhibitors. They both work to reduce the inflammation in the skin. That's the T for topical and ultraviolet terror.
UV and topical.
Got it.
What if that's not enough?
Good question. If it's more severe or widespread or not responding well to topicals, then anti-malarial drugs are often used, like hydroxychloroquine.
Oh, antimalarials. How do they help?
They have this sort of immunomodulatory effect. They help calm down that overactive immune response.
I see.
And for really stubborn lesions, you might use stronger immunosuppressive creams or more potent steroids, maybe even injections into the lesion itself sometimes.
Okay.
And if the disease is really widespread, then systemic therapies might be needed, things like oral steroids or other immunosuppressant medications.
Right, stepping up the treatment.
Exactly. And then, dealing with the consequences, like scarring. Sometimes surgical options can be considered, or things like photodynamic therapy or laser therapy in certain cases.
A whole range of options then.
Yeah.
So thinking about the long term, what's the usual outcome? The prognosis?
Generally, if it's caught early and treated properly, DLE is manageable for most people. The skin lesions can often be controlled.
That's good to hear.
But it's important to remember that risk of progression to SLE. It's estimated around 5 to 10% of DLE cases might eventually develop systemic lupus.
Okay, so a relatively small but significant risk.
Yes. And that risk is thought to be a bit higher if someone has the generalized form of DLE rather than just localized.
Right.
And the flip side is if it's not treated, you're looking at those permanent problems. The scarring, the hair loss, the pigment changes. So remembering that small percentage might go systemic is a key part of the prognosis picture.
Understood. And apart from progression to SLE, what other complications can crop up with DLE?
Well, the scarring itself is a major complication, obviously, and scarred or damaged skin is more prone to secondary infections.
Makes sense.
There's also the emotional impact. Changes in appearance, especially on the face or scalp, can cause significant distress.
Yeah, that's really important to consider.
Definitely. And as we said, that small group, maybe fewer than 5% who do progress to SLE. Also, if someone already has SLE and then gets DLE lesions, they might have a higher risk of photosensitivity and low white blood cells, leukopenia.
Okay.
And although it's rare, there's a small risk of skin cancer developing in long-standing chronic DLE lesions, specifically basal cell or squamous cell carcinoma.
Wow. Okay, so monitoring is key there too.
Absolutely. And one last thing, particularly for people with darker skin tones, the loss of pigment, the depigmentation in the lesions can actually reduce the skin's natural protection against the sun in those areas.
Ah, creating another vulnerability. Okay, so lots to manage and monitor. We've covered a huge amount. Those mnemonics you mentioned earlier seem really helpful for revision.
Yeah, hopefully. Just to quickly recap them, for risk factors, for us guys, smoke.
Female UV genetics, smoking. Yep.
For differentials, some do prefer a large wart sitting squarely cutaneously.
That long one. SLE, dermatomyositis, psoriasis, AK, lichen planus, warts, arcoidosis, SCC, CTCL. Got it.
Linking discoid to coin-shaped lesions and potential hair loss. And for management, ultraviolet terror, minimize UV, use topicals.
Brilliant. And just to really cement the knowledge, what sort of questions could listeners ask themselves?
Good idea. Maybe something like, what are the key differences between discoid lupus and systemic lupus?
Okay.
Or list 3 important risk factors for DLE. Another could be, describe how a typical DLE lesion changes over time.
Right, the progression.
Yeah. Also, what's the main goal of DLE management? And maybe, what's the rough percentage risk of DLE progressing to SLE?
Perfect. Those really hit the key points. So wrapping up our deep dive on Discoid Lupus Erythematosus, we've seen it's this chronic autoimmune skin issue with very specific features, risk factors, and this immune attack mechanism.
That's it.
And while it's mostly skin limited, distinguishing it from other things and managing it well is vital to prevent scarring, hair loss, and those other complications, including that small chance of it going systemic.
Absolutely. Early recognition, sticking to the management plan, that's crucial.
Understanding these nuances, like with DLE, it doesn't just help manage the condition, does it? It also kind of shines a light on how incredibly complex our immune systems really are.
It really does. Fascinating, even when it goes wrong.
Definitely. Well, if this has been useful for your revision, you can find more resources over at PassThemMSRA.com.
And for extra study materials and support, check out freemsra.com.
Thanks for joining us on The Deep Dive.